So is everybody ready to start? We just had a late connection. I see everybody in Athens. Do we have?
There is nobody in Albany.
There's nobody in Albany?
I think they're all in Athens.
All the Albany people joined us in Athens today.
Okay, what about Savannah?
I think it's the same, but I need to event tonight in Athens.
Okay. Well, that's.
I think everyone's in Athens today because of the ping ceremony.
Yes.
Except for
no,
Augusta.
We have a critical mass here in Augusta, but they'll be heading out of there later today. And I know some of our people are in.
Yeah, can't leave.
Already in Athens. So this is convenient that I want to address you because we have a quiz this morning. And I want to stress what was said at the beginning of the semester is there is absolutely no use of your resources, your notes. There has been reported to me and Dr. Clements that people are using notes while doing the quizzes. And we trust you not to do that. So don't do that. This is a way to test your own knowledge and your preparation. They're low stakes. And we're about to trust you with our dearest resource, our patients. So we have to be able to trust you in these types of things. So do not look at your notes while doing your quiz. Dr. Clemens will speak to you again about this on Monday. We're taking it very seriously. And please make sure that our trust is not misplaced. So I'm going to hand it over to Dr. Saunders, who's going to start the class.
Thank you. All right.
Right. Good morning, everybody. While I try to pull up the slides for you all, there is a quiz today, and I believe the password is solid.
Solid.
S-O-L-I-D. If that does not work, then it's solid. Alrighty, I think, are most people done with the quiz? Keyboard thing. Alright, so today we will finish up with colorectal cancer. As a reminder, here are the objectives for this portion of your course. Any questions about the pre-class lectures before we get started with these slides? Okay, and this is just a reminder from the pre-class lecture, just broadly speaking, how we manage colorectal cancer and what our goals of therapy are for the different stages. So as I mentioned for the previous slides, stages 1, 2, and 3, our goal of therapy is cure. So we have kind of a combination of different treatment modalities we can use. For stage 1, it's primarily just surgery, but our higher risk stage 2 and 3 patients will receive some sort of combination of surgery with chemotherapy, and some people are eligible for radiation. And then for stage 4, we do have that about 20% of patients who present with metastatic colorectal cancer that may be resectable either before they receive chemotherapy, if it's maybe one spot either in the liver or lung that can be removed along with the primary tumor, or patients who become resectable following chemotherapy and then can go on to surgery. So something somewhat unique about stage 4 colorectal cancer that you may not see in other metastatic solid tumor cancers. So we're going to start looking at a little bit more in detail the neoadjuvant and adjuvant treatment options for colorectal cancer. So as you may recall from the other slides, our kind of mainstay of treatments are FOLFOX, which is folinic acid or leucovorin, fluorouracil or 5-FU, and oxaliplatin. We also have the option of capecitabine and oxaliplatin, which is called CAPOX, with capecitabine being the oral prodrug for 5-FU or fluorouracil. So these are very similar regimens that you can use. There's also some options for single-agent capecitabine or single-agent 5-FU with leucovorin, and these are often used with radiation. These agents are considered radiosensitizers, so they help the radiation to work better And you can kind of use lower doses of both the chemotherapy and the radiation since they're synergistic when used together. And then for patients who fall into that 20% of stage 4 cases that may be curable with surgery, you can use any of those options, but then you also have the option of FOLFIRI, which is rather than oxaliplatin, irinotecan. All right, so we're going to focus a little bit on the medications more in detail. These are all probably drugs that you won't really see in any other cancers that we cover in this course for pharmacotherapy, so we'll spend a little bit of time talking about them. And you've probably talked a little bit about leucovorin already, maybe in the setting of high-dose methotrexate, but it does have a different use here in combination with 5-FU than it does with methotrexate, so we'll talk about that. All right. So in general, the two most common regimens that you'll see for colorectal cancer are FOLFOX and FOLFIRI. These are very commonly used in both the neoadjuvant, adjuvant, and metastatic setting, and it is typically dosed, as you can see here, on days 1 and 15, and so patients will come to the cancer center every 2 weeks to get their 5-FU bolus, the leucovorin, and then either oxaliplatin or irinotecan, and then both regimens have the patient going home with a pump of 5-FU for about 46 hours after. So they end up receiving the fluorouracil over 48 hours every 2 weeks. So it's something a little bit unique with this, that they actually go home with a little pump and receive the chemotherapy while they're at home. And then they'll usually come back to the clinic after that 48 hours is done and have the pump disconnected from their ports. This is something, since they go home with this continuous infusion, they do require permanent central access. So these patients usually have a port in place that is the pump is hooked up to and then disconnected by a nurse. And sometimes you have very health literate patients who are really able to do this on their own, and they can get some teaching and disconnect the pump on their own at home, but I'd say the vast majority of patients end up coming back to clinic. And so we do these doses every 14 days, so the patients in a month will receive 2 rounds of chemo. So talking a little bit more in detail about fluorouracil, or 5-FU. So it is an anti-metabolite. It's a pyrimidine analog. It's similar to uracil, but obviously has the fluoro attached to it. There are a lot of different doses for this medication for several different malignancies. So we use 5-FU in a couple of other places, but it's very commonly used in GI cancers. The dosing is typically in colorectal cancer, the bolus followed by the continuous infusion, but there's some variation in the milligrams per meter squared dosing for this medication. So you won't have to memorize any of that for the exam, just more knowing that it is typically a bolus followed by the continuous infusion. The toxicities that are listed here, myelosuppression, diarrhea, mucositis, hand-foot syndrome, neurotoxicity, and cardiotoxicity. These are the ones that we kind of focus on when we're counseling patients. Note that the hand-foot syndrome is bolded, so this is something definitely to remember about 5-FU. Patients can develop this hand-foot syndrome, and it's just a reminder in case you've either, it's been a while since you've talked about it or haven't, it's also called plantar palmar erythromesia, so it's this redness and irritation on the palms of the hands and soles of the feet. It almost looks in the beginning like a sunburn. That's how I kind of describe it to patients, where it's really red and irritated, and then it can progress to ulcerations, peeling of the skin, really dry skin, and can cause a patient to need dose reductions or dose interruptions if it's very severe. Not only is it potentially very painful for patients, but it's also a potential source of infection. So it can cause a lot of issues. This is not the only medication that causes this side effect. There are several other medications where we have to counsel patients on this. Capecitabine, since it is an oral prodrug of 5-FU, has this same toxicity. And there's some pertinent counseling points that we can go over with the patient case to help patients reduce the risk of developing hand-foot syndrome, and then how to manage it if they do have it. One of the things noted here on the slide are urea-based creams are really helpful for patients to use. So there are some strengths that are available as over-the-counter, and then I believe it's 40% and higher require a prescription, but it's something that patients can also get over-the-counter and use to help prevent and treat hand-foot syndrome. And then, of course, our monitoring are kind of standard with traditional cytotoxic chemotherapy, CDC, renal function, and hepatic function. We typically won't dose adjust 5-FU for those toxicities, but some of the drugs we're using in combination with it may require a dose reduction for that. All right. So we have here a brief summary of the mechanism of action of 5-FU, and then of course what we're using the leucovorin for. So leucovorin in this case is actually helping to potentiate the effects of 5-FU and help it to work better. So unlike high-dose methotrexate, where we're using leucovorin as a rescue agent due to the extensive myelosuppression that can happen with high-dose methotrexate in the absence of leucovorin, where it's really serving as that folinic acid rescue for DNA synthesis. This is actually helping the 5-FU to work better. So the LV here in the slide is where we're hoping to potentiate the effects of 5-FU. So as you can see here, 5-FU causes, in multiple pathways, RNA and DNA damage. Here we also have listed where methotrexate is working and that the leucovorin is a rescue agent. But just know, broadly speaking, leucovorin's mechanism of action in this regimen is not the same as methotrexate. It's actually to help the 5-FU, particularly the bolus, to be more effective. I do want to mention the toxicities between the bolus and the continuous infusion do vary a little bit, and I just mentioned this on this slide. We tend to see myelosuppression more with the bolus dose of 5-FU, whereas some things like the hand-foot syndrome tend to be more the continuous infusion. So one thing that can be modified for these patients is if they're having a lot of myelosuppression, sometimes, especially in the metastatic setting, if they're not curable, the physician will drop the 5-FU bolus just to help alleviate some of those side effects. And then in that case, technically the leucovorin may not be as necessary. The leucovorin helps to kind of extend the action of the bolus to give it more efficacy, but if we're giving the 5-FU over a continuous infusion, the leucovorin isn't really required. But you'll often see patients, if they drop the 5-FU bolus, they'll stay on the leucovorin. It's not necessarily wrong, it just may be unnecessary. But just kind of also keep in mind that's something that we can do to modify the regimen to make it more tolerable. But generally speaking, for the purposes of the exam, I won't ask you that minute of a detail. Like if this patient comes in with neutropenic fever, would you rather dose reduce the continuous infusion of the bolus? But just kind of keeping that in mind that you may see a patient where the bolus itself has been dropped along with the leucovorin, and that might be why. It's just they're trying to optimize the tolerability for the patient. And as I mentioned, so capecitabine is going to look very similar as far as toxicities and monitoring. It is an anti-metabolite as well and is the oral prodrug for 5-FU. There are lots of different doses of capecitabine that you may encounter. It is an oral medication and is typically given twice a day. There's some variation with this, but in colorectal cancer, patients will usually take it for 2 weeks in a row and then have that 1 week off to recover from toxicities and allow their counts to recover. It is recommended to take within 30 minutes after a meal. There are some dose adjustments in this case for renal dysfunction. So as you can see here in the toxicity box for this slide, very similar to 5-FU, but patients will have potentially more hand-foot syndrome with capecitabine. Patients also get a decent amount of diarrhea with this medication, so some things that are worth counseling a patient on and may require dose adjustments of the oral medication. With the drug interactions, the proton pump inhibitor or PPI drug interaction, it can impair absorption of capecitabine. This comes up a lot though for patients where we try to do other methods for controlling their reflux symptoms, or if they have a diagnosis of GERD or they're on a PPI prior to starting, transitioning them to maybe an H2 antagonist. But oftentimes we have patients who still are unable to tolerate not being on the PPI. So it's something worth discussing with the physician, the risks and benefits, and of course the patient's goals of their treatment, if they're curative and we're worried about reducing the absorption versus if it's palliative and we're trying to increase their quality of life and make sure we're managing all of the side effects as well as we can. possible that patients will end up on a PPI even though they're on capecitabine, and there are some studies that look at how much of the absorption is actually altered and whether or not it's clinically significant depending on what you're treating. But overall, we do try to avoid the use of PPIs with capecitabine. And then, as you can see here, warfarin is another big drug interaction with capecitabine. It can increase a patient's INR, and this does have a box warning of using capecitabine and warfarin together, so definitely something to bring to the attention of the providers. We often don't have patients anymore on warfarin for VTE if they have cancer. As you may recall from previous lectures, our standard of care for a long time was Lovenox or enoxaparin. But there have been several studies in the last year that have looked at the direct oral anticoagulants, particularly the anti-10As like apixaban, rivaroxaban, and edoxaban, that they may be just as effective for patients for VTE if they have cancer. So you may not see as many people on warfarin anymore along with capecitabine, but you'll still have those patients that maybe have AFib that have been stable on warfarin for a long time, or may have a contraindication to the DOACs where they need to be on warfarin. So this is something that requires increased monitoring and communication with the anticoagulation team that's managing the patient and potential empiric dose reduction. So definitely something to keep in mind for these patients. Okay. Oxaliplatin, if I think about other indications for oxaliplatin, I think it's primarily going to be used in our GI malignancies. So some of the toxicities that we've talked about with other platinum agents apply here, but there are a couple of unique aspects about oxaliplatin. So it is that same mechanism of action, that it's an alkylating agent since it is in the platinum class. Lots of different doses available depending on whether it's in combination with 5-FU or capecitabine. And we do have dose adjustments that are recommended for renal impairment. For the neuropathy, you may recall that we talked about neuropathy with both carboplatin and cisplatin. Can occur with oxaliplatin as well, but one thing to make sure to counsel patients on is there is a more acute form of neuropathy with oxaliplatin. It's actually this intolerance to cold, and tends to happen within a few hours up to maybe a few days after the infusion itself. So in patients who are receiving oxaliplatin, they do have to be counseled to avoid very cold beverages, touching things that are really cold. I did my PGY2 up in Wisconsin, so we would have to counsel them to make sure to wear maybe 2 layers of gloves if they were coming in and out of treatment and it was the winter because of how cold it is outside. So they are very sensitive to cold, and so even if they drink a very cold beverage, go into the freezer and try to grab ice cubes, it can be really painful. So making sure they're aware of that it can happen while they're in the infusion area for a few hours after, and then I've seen up to a few days after treatment itself. So something that they should avoid interacting with very cold objects right around their infusion, but it tends to go away. So it's definitely a time relationship to their treatment. Similar to the other platinum agents that I mentioned, there is the possibility for hypersensitivity reaction, and then some of those other toxicities are possible, but maybe less frequent, such as the nephrotoxicity, ototoxicity, and myelosuppression tend to be more common with the cisplatin and carboplatin regimens than oxaliplatin, but it is something that can occur. But definitely the unique aspect of cold intolerance and neuropathy is important to discuss with patients receiving oxaliplatin. Okay, so the next agent, irinotecan, it may have come up in other lectures. There are several indications for irinotecan even outside of GI, but this tends to be where it's very commonly used. It is a topoisomerase 1 inhibitor. There are dose adjustments for hepatic dysfunction, and the kind of unique toxicity with irinotecan is the diarrhea. There are 2 different types of diarrhea that can happen with irinotecan. One is a more acute diarrhea that's essentially during the infusion, and that's more the cholinergic symptoms that happen with irinotecan. So patients, it can come up very suddenly, and the way we manage the acute diarrhea is with atropine, an anticholinergic agent. A lot of centers will use atropine as a PRN medication during infusion. We have one provider here that has opted to kind of pre-medicate everybody with atropine prior to their irinotecan infusion to just help prevent some of these cholinergic symptoms that can happen acutely. But both are potentially options. The late diarrhea, which can happen up to several days after irinotecan, is actually managed with over-the-counter Imodium or loperamide. A very important counseling point prior to starting a regimen containing irinotecan is that patients should really have the Imodium on hand rather than waiting until they develop diarrhea and then trying to go find Imodium, because this can lead to severe dehydration, potentially AKI, and hospitalization if the diarrhea is severe enough. And I won't have you memorize the dosing for loperamide, but it is an off-label dosing where they will, if they're developing diarrhea related to their irinotecan, they will exceed that maximum 16 milligrams per day that you see on the over-the-counter labeling, and that's okay for these patients. They typically will do the 4 milligrams at the first sign of a loose stool, and then they repeat a 2 milligram dose every 2 hours until they are without diarrhea. And if they're asleep, then we let them extend it to every 4 hours, but they still have to kind of be on a scheduled loperamide dose until the diarrhea resolves. So they may very well exceed that 16 milligrams, but it's more important to kind of get on top of the diarrhea earlier rather than later. But just know that loperamide is our first choice option. We can do other antidiarrheals if they don't respond to loperamide. Usually patients do though, but if it kind of gets away from them and they're starting the loperamide a little late and then they're dehydrated and come into the hospital, then we have other things such as Lomotil that we can add on to try to help control their diarrhea. This is different though than say when we were managing immune-mediated diarrhea with those immune checkpoint inhibitors. This is more, though it's a late diarrhea, it's not something that will present weeks after completing irinotecan. It's still usually within a few days of their infusion, and their risk several days later is probably a lot lower. But the acute diarrhea in this case is essentially either during the infusion itself or immediately thereafter. So typically that acute cholinergic symptom period is when they're still in the infusion center. And there's some other side effects listed there of irinotecan, but diarrhea and cholinergic symptoms are definitely the most important to remember. And if you have a hard time remembering, the way I was taught it was to remember irinotecan, I run to the can for diarrhea, so hopefully that will help. All right, so we're going to go through our first case. So this is patient NT, he's a 61-year-old male who presents to the ER. He has a 4 to 5 day history of diarrhea, blood in the stool, frequent gas pains. He's severely anemic, and so they proceed to a colonoscopy. So it's noted on the colonoscopy that there is intestinal necrosis, ulceration, and bleeding. And so a biopsy is taken of this abnormal finding on the colonoscopy. Here are the patient's past medical history and family history. So he does have a history of inflammatory bowel disease as well as diabetes. His father had colon cancer diagnosed at age 62. He is a smoker and also drinks 5 to 6 beers per day. And there are some of his pertinent vitals if you look at. So before we get more into the treatment for NT, what are his risk factors for colorectal cancer, and then are there any other labs or workup that need to be performed? So we'll just take a few minutes to do that. So what are some of the risk factors that this patient may have for colorectal cancer? Maybe increase your suspicion.
He has IBD and type 2 diabetes.
Oh, perfect. So someone here in Augusta said his past medical history, so he does have a history of both IBD and type 2 diabetes. In everybody else in Athens, anybody have any other risk factors they wanted to mention?
He is a smoker. He has a family history of colorectal cancer. He also uses alcohol, and he's over the age of 50.
Perfect. Yes. So I think that is all of them. So over the age of 50, he has a first-degree relative with a history of colon cancer, his father, and then he smokes and drinks alcohol along with the past medical history. So definitely seems to be kind of a high-risk patient. Hopefully, with getting his screening colonoscopies, but. Any other labs or workup that you would like to know?
You'd want to get an image of the abdomen, pelvis, chest, and then other lab tests like blood counts, LFTs, INR, renal function tests, and a CEA.
Perfect, yes. So definitely some imaging of both the chest, abdomen, and pelvis, kind of assess what's going on. And then our basic lab workup, CBC, chemistry, that includes LFTs, INR, et cetera. And then our CEA is just kind of a baseline to see what's going on there. Okay, so all of that workup is completed. The biopsy results come back, and it turns out the patient does have stage 3B colorectal cancer. So they want to do a partial colectomy, and then the patient should receive adjuvant FOLFOX. So we won't spend a lot of time on this, but since this patient is stage 3B, what is the goal of treating his disease at this time?
The cure.
Cure. Okay, perfect. And then as far as how long should the adjuvant therapy be administered, I didn't really spend a lot of time on this because there's actually a little bit of maybe a change in practice with adjuvant treatment for colorectal cancer. The standard has been for a long time to do 6 months worth, so essentially 12 doses potentially of FOLFOX or KFOX, but there were some studies published last year that evaluated whether patients really need a full 6 months or can we do just 3 months. And I don't know if we have like full long-term results on that yet, but it looked to be that 3 months was non-inferior, so the guidelines have included some of that wording that 3 months of adjuvant treatment may be non-inferior to 6 months, but some centers are still doing the full 6 months of treatment. It appears, though, that maybe doing 3 months of treatment, you get the same benefit for prevention of disease recurrence with a lot less toxicity. So that's something that is kind of a moving target, but just know the patient may receive either 3 to 6 months of adjuvant treatment following surgery. And so if the patient is starting on FOLFOX, so just as a reminder, that's 5-FU with leucovorin and oxaliplatin. Just take a couple moments to decide what baseline monitoring prior to therapy, and then what we're going to kind of monitor throughout treatment, and then some key counseling points that you want to tell the patient before they start therapy. Alrighty, so what baseline labs and monitoring throughout treatment would you like to recommend?
CBC, liver and renal function.
Okay, great, yes. So in Augusta we had CBC, renal function, liver function. So yes, that's typically what we will get each time. And then as you may recall from the pre-class lecture, CEA, we like to get it at baseline, but it may not be elevated in every patient. Oh, yes. Sorry, was there someone going to chime in?
I think it's just off the mic.
Oh, yes, sorry, there's a question.
I think it was the 5-FU, there's a possibility of cardiotoxicity. Would you do an EKG or any kind of baseline for that?
So that's a good question. The cardiotoxicity, the anti-metabolites in general, what we tend to see, so this will apply to like gemcitabine and some of our other ones, is they can get this like ischemic looking picture where it's almost like chest pain, and then rarely it has more of an ischemia type presentation as opposed to maybe cardiomyopathy, though it's not impossible. We don't necessarily get echoes and EKGs for every patient. I think it would depend more on their risk factors and other comorbidities. A lot of times though we will get at least an EKG at some point during baseline, and then in the presence of maybe chest pain or some other type of symptom that leads us to think they're having a cardiac event, we'll monitor, but there's not necessarily a set monitoring for these patients. A lot of times though, especially in someone that's getting adjuvant treatment, they will get a full cardiac workup prior to surgery and make sure they're a good candidate for the surgery itself, and then you can kind of monitor after that. That's one of the benefits, though, hopefully, of shortening the duration of adjuvant treatment is we have less of those toxicities in addition to things like neuropathy, which can be cumulative with the platinums. But it's something for a patient like this, he doesn't necessarily have a lot of cardiac comorbidities, but we're educating the patient about, and then if anything were to change during therapy, then getting EKGs and kind of going from there. But that's definitely something to keep in mind. And And then the CEA, as I mentioned in the pre-class lectures, not every patient will have an elevated baseline CEA, but is something that we could maybe monitor throughout treatment if it was elevated to assess for response. And then even if it wasn't at baseline and you start to notice a trend upward that maybe your treatment isn't working, but in the setting of a successful surgery with negative margins and we're doing adjuvant treatment, I think you would expect hopefully that the patient wouldn't develop disease recurrence in that time. So for counseling points, we've kind of mentioned the potential for cardiotoxicity. Any other things that you'd like to counsel your patient on for FOLFOX? Yes. So we mentioned the cold. Yes, so cold intolerance with oxaliplatin, and then potentially the development of hand-foot syndrome and diarrhea with the 5-FU, as well as your kind of standard cytotoxic chemo counseling points like neutropenic fever, myelosuppression, etc. For the hand-foot syndrome, there are a lot of non-pharmacologic things that patients can do to help prevent the development of hand-foot syndrome. So we, similar to the oxaliplatin, avoid really, really cold things. We actually tell people to try to avoid doing dishes or taking really hot showers with hot water. The really hot water can cause the vasodilation, which may worsen a hand-foot syndrome or increase the likelihood that it will happen. And then avoiding activities that cause a lot of friction on their palms or soles. So if someone, this comes up every once in a while, someone's an avid gardener, avid golfer, something like that, where they're having to grip really hard on a maybe rougher surface, that they should wear gloves that have a lot of good soft lining on the inside to help protect their hands. We try to avoid telling people they can't do those activities because then it kind of is, it can be really upsetting for patients, but as long as they're willing to buy like a really nice set of gloves to protect their hands during those activities. If they're walking around outside, making sure that they're wearing good shoes with nice soft socks to avoid applying a lot of pressure to their soles, that helps a lot too. And they should look at their hands and feet frequently during treatment and make sure they're not developing any peeling skin or ulcers. It's something they've noticed really easily on their hands, but they may not notice on their feet. And then moisturize. So I had mentioned the urea-based creams. Keeping the skin really well moisturized helps a lot. Patients who have really dry, cracking skin are much more likely to develop hand-foot syndrome. In the case of 5-FU, when the medicine is actually infusing, we try to avoid applying a whole lot of lotion because there's a lot of friction potentially. But once they've completed their infusion, gently applying fragrance-free, mild-type lotions or creams. Nothing too thick like an ointment that they have to really rub into their skin aggressively, but just something that's for sensitive skin helps to prevent that and keep their skin from cracking and potentially causing hand-foot syndrome. So definitely lots of things that the patients can kind of do up front to help hopefully mitigate any hand-foot syndrome. But avoiding the really hot water and friction on their hands and feet are good counseling points to keep in mind. All right. So we're going to talk a little bit about our second patient case. So this is a patient ES, 38-year-old female. So a little bit younger than our normal patient with colorectal cancer, but as you can see has a history of FAP, which is a risk factor for colorectal cancer. So she's receiving her surveillance colonoscopies and a suspicious mass is found. When it's biopsied, it shows stage 2C disease, and this patient is going to receive neoadjuvant CAPOX or capecitabine with oxaliplatin prior to surgery. So for patient ES, what is the goal for treating her disease? So cure. So again, yes, earlier stage cancer, stages 1 through 3 are definitely curative, and then we have our 20% of stage 4 patients that may be curative as well. And as I mentioned, somewhat controversial, but how long would you expect the neoadjuvant or adjuvant therapy to be administered?
3 to 6 months.
Yes, it says someone here to 3 to 6 months. So kind of depends a lot on the patient in particular, and then as this new data comes out as to whether or not 3 or 6 months has an impact on the patient's overall survival, will kind of help us to lean towards one or the other. But right now the guidelines are a little bit more vague on this area, just based on recent studies that have come out in the last year. Alrighty. So for baseline monitoring in Athens, anything that you would like to get prior to starting capecitabine and oxaliplatin, that might be anything different from the FOLFOX patient we just talked about?
Iron fluid warfarin.
Yes, perfect. So the monitoring is very similar since it is a prodrug. We kind of approach this regimen very similarly, but if the patient is on warfarin, making sure to get an INR prior to therapy and monitoring more frequently. And then we do have the potential for dose adjustments if there is any renal dysfunction with capecitabine. Any counseling points that are that you want to highlight with this regimen that might be either a little different for KBOX as opposed to FOLFOX? Yes, so here in Augusta, somebody said higher risk of hand-foot syndrome. Anything related to the capecitabine in particular?
It's oral.
Yes, so oral medication within 30 minutes after a meal, and it's typically going to be twice a day. So just highlighting that for the patients. There is some potential for questions about special storage. So we talked a little bit about this with our other oral agents in lung cancer and melanoma. It's a little different with capecitabine only because this is actually a cytotoxic chemo. So it will get kind of labeled all over the place with chemotherapy drug, and they should store it separately. When the pharmacy is dispensing it, when I worked in our specialty pharmacy as a resident and we were dispensing cytotoxic drugs like this, we wear gloves when we're counting and double checking these. So they have a little bit more recommendations to them for patients. So really, if the patient can be the only person handling the medication, otherwise someone should wear gloves if they're handling it. And then storage, since there's the potential for residue on the bottle, we like for them to at least, if they can, throw it away in the chemo bag that we at least dispense it in, and in a trash can that definitely little ones and fur babies can't get to. But otherwise, some patients bring their bottles back to the cancer centers, and we can dispose of them in the hazardous drug waste. It's not required, but it is a little bit different with this medication as opposed to our targeted therapies that we talked about, where there's the potential for a little bit more risk of exposure for somebody else. But overall, though, as long as they're not manipulating the tablets, the likelihood of someone being exposed to the chemotherapy is really small. So making sure they're not cutting or crushing these at home and that they're keeping the tablet intact. They come in 500 milligram and 150 milligram tablets as a side note for capecitabine, so we'll round to the easiest whole tablet that they can keep track of, where it's not too many different doses and tablet forms, but there shouldn't be any need to do any manipulating of the tablets at home. All right, so if we're talking about Miss ES, so 4 years later, so she completed her perioperative capecitabine and oxaliplatin after her surgery, but she comes in with right upper quadrant pain, and they do a PET scan, and it shows that she has recurrent colorectal cancer, and she has metastases to the liver, and they're deemed unresectable at this point. So she is no longer a surgery candidate. The physician wants to treat her with FOLFIRI. So this is very common in a patient that, essentially she had the oral version of FOLFOX, so they'll often switch at the time of disease recurrence or disease progression to irinotecan or vice versa, depending on what they got first. So just take a couple of minutes for the goal for her, treating her disease, and then what counseling points you want to talk about with her for FOLFIRI. That might be a little different. Alrighty. So what is the goal for Ms. ES's treatment at this time? Yes, so palliative. So unfortunately, if the metastases in either the liver or the lungs are unresectable and they don't think they'll necessarily be able to make them resectable with neoadjuvant chemo, then they are a palliative candidate. And that's going to be the majority of patients that have metastatic colorectal cancer. And then in Athens, what are a couple of counseling points you have for FOLFIRI?
monitoring for hand-foot syndrome using urea-based creams if needed, monitoring for the diarrhea from the irinotecan and the cholinergic symptoms, as well as myelosuppression, potentially looking out for neutropenic fever as well.
Okay, perfect. So yes, so neutropenic fever, the other kind of counseling points that come along with myelosuppression, hand-foot syndrome, but then definitely diarrhea since she'll be starting irinotecan, and kind of letting the patient know it's possible to be acute or delayed and making sure they kind of have what they need at home as far as the having loperamide available and the special dosing. I do tend to spend a little bit of time with patients and let them and the caregiver know that the dosing is different than what's on the package itself and that it's okay, because a lot of times what may happen is if you don't get a chance to highlight that with the patient, they'll do just kind of what the box says, and that may not be enough loperamide if they're on irinotecan. And if you look in like off-label dosing in some of your drug references, like Lexicon for Micromedics, they'll have the OTC labeling, off-label dosing for chemotherapy-induced diarrhea, and then there'll be a special one that says irinotecan-induced diarrhea. So that's the one to kind of highlight to patients. And a lot of times it's just easier to give them a prescription, and that way they have it written out for them. It can be kind of a lot for them to remember all at one time if you're counseling them right when you're starting. Okay. So for this patient, she receives 2 cycles of FOLFIRI and then comes into an urgent clinic appointment, severe diarrhea for the past 4 days, with 8 to 9 stools above baseline. Has an increase in sodium, creatinine, and BUN, so diarrhea is bad enough where she may have an AKI at this point and she appears to be dehydrated. And so what is the likely culprit? And we've kind of talked about this, and then how would you want to go about deciding if there needs to be an adjustment to her therapy? And this is more theoretical, not necessarily a specific dose adjustment that you have to recommend. And also, what would you like to ask the patient as far as maybe specifics about their diarrhea and what they've done at home? Maybe here in Augusta, what do you guys have? Do you want to ask her at least? Yes, so that's a great question. So asking the patient whether or not they took the loperamide and did they take it as directed. And if the answer is yes, she did do exactly what she was supposed to do and it still isn't responding, a couple of things that I like to keep in mind. So this is more just how to approach these questions. When it comes to a patient that is maybe palliative treatment intent, we may not need to keep all of the doses at the max dose for her if it's creating this much of an issue with side effects and potentially impacting quality of life. Having intractable diarrhea with 8 to 9 stools a day sounds really terrible. So it might require a dose adjustment in the chemotherapy. Most likely it's the irinotecan, but 5-FU can also cause diarrhea. So what we will typically do in clinic is grade the diarrhea. So it's going to be similar to the way you do the immune checkpoint inhibitor grading, where a certain number of stools above baseline will correlate to grade 1 through 4. And then if you go to the package inserts for irinotecan or 5-FU and look at grade 3 to 4 diarrhea, grade 3 to 4 toxicity, it'll have dose levels that you can go down on. That way it's evidence-based, it's mimicked on how they adjusted the doses in the clinical trials. So it's a really good reference to use as far as, do you go down 20%, 30%? Sometimes it can seem a little arbitrary, and a lot of times the oncologist will dose adjust based on their expertise and experience that they've had managing these patients, but when in doubt, they usually, especially for something like irinotecan, for the diarrhea, the package insert has kind of like what dose level to go down on based on where they started and how to modify their therapy. If it's to the point where even dose adjustments don't really address this issue, that's when you have to think about maybe switching therapy. But in a patient that's only received 2 cycles, we're not really sure yet if it's working. So you'd want to try to keep them on schedule and keep them on this therapy until you get a scan. But either dose reducing or giving them a little bit of a break in the setting of palliative treatment are all good options to make sure the patient's able to maintain their quality of life. So just more how to think about it and what to do time. This comes up a lot if these patients get admitted to the hospital. You know, the team managing them while they're admitted is not going to necessarily make any changes to their therapy, but as a pharmacist on the team, if there is a pharmacist on the outpatient side that you can kind of communicate with and problem solve with, making sure that recommendations maybe for the next cycle get communicated so that they can be on the lookout for changes to their regimen and aren't surprised when there's dose adjustments that come through. So I think that's really helpful. It's something that we run into a little bit at the cancer center here because we're still on paper chemotherapy orders, unfortunately. We're hoping to get that changed in the next year or so, but sometimes issues that happen on the inpatient side, that's all on electronic and things like that, but then you have the cancer center is still a lot of their information is on paper and they're less in the electronic health record than you would be on the inpatient side. These nuances to therapy changes get missed, so always over-communicate with your colleagues on the inpatient and outpatient side if you can in your own rotation. Yes, question here in Augusta.
Do y'all ever do anything in the lab C-diff, or do they present differently?
No, so we typically will do an infectious workup even in this scenario. For patients with irinotecan, I mean, we have them do the loperamide at home because we're much more likely to have diarrhea, whereas like the immune-mediated colitis with immune checkpoint inhibitors isn't as common overall as you would expect diarrhea with irinotecan. So we would prefer, if we can, in those settings with immune checkpoint inhibitor to get a stool sample and rule out an infectious cause. In a patient like this, that's a very good thought. If they've been doing their loperamide as they were instructed and they're still not any better, they either have very bad diarrhea from the chemo and it needs to be dose adjusted, but if they were to come to clinic looking like this, then more than likely they'd get a stool sample and just make sure it's not either C. diff, because these patients are in and out of the health system a lot, or even like a foodborne type infection. So definitely other good questions to ask, whether or not they're febrile at home. That would help you kind of determine if something is potentially infectious. That's the question. All right. Any other questions about the cases or kind of adjuvant therapy? So the next few slides are going to be about some of the options we have for patients who are metastatic and things that we do a little bit differently. You're going to see some of the exact same regimens. So in that sense, colorectal can be a little simple. FOLFOX is always the answer, is what I've told. What the GI oncologist they did residency with. And that's not necessarily the case, but But any questions? Okay, so as I mentioned, so if we're looking at a patient kind of like ES where you have, it's unresectable stage 4, so these are patients that are palliative. As you can see, a lot of the same regimen, so you have FOLFOX or FOLFIRI. In a patient who presents as metastatic, we can do either or, and then they'll switch if there's disease progression or a dose-limiting toxicity of some kind. So either are an option as first line. And then we'll talk a little bit more about panitumumab and cetuximab, but these are EGFR inhibitors, but they are IV as opposed to, the oral ones that I mentioned for lung cancer. These are IV monoclonal antibodies that target the EGFR. You still have KFOX, and then another somewhat different one is FOLFOXIRI. It's just FOLFOX with irinotecan, or however you want, or FOLFIRI with oxaliplatin added into it. So you're kind of giving them a lot more chemotherapy up front. Whether or not to add some of these other agents that you see up there, bevacizumab, ramucirumab, and aflibercept, these are all vascular endothelial growth factor receptor, or VEGF inhibitors. And a lot of that can be patient-specific on whether or not they qualify for those. So we'll talk a little bit more about those medications and maybe how you would decide if a patient should get those. But it's often that we can add those on to certain patients. And then we won't spend a whole lot of time. There are lots of subsequent systemic therapy for unresectable stage 4. As I kind of alluded to, if you start with FOLFOX and then they have disease progression on FOLFOX, you can switch to FOLFIRI and vice versa. The immune checkpoint inhibitors, this is their place in therapy for colorectal cancer. There is a caveat with that though. They do have to have these particular genetic mutations present, either MSI high, which is microsatellite instability. So this is more, and the MMR. These are tests where they look at how unstable is the DNA within the cancer cells, and the more unstable some of these tests are, the more likely a patient is to respond to an immune checkpoint inhibitor when they have colorectal cancer. They're starting to look at this test to help determine in other cancers whether or not people will respond to immune checkpoint inhibitors, but that's very specific. Just know that there is a place in therapy for the same drugs we've kind of already been talking about with other cancers. It's typically reserved for the second-line setting unless you have a patient who is MSI high, so high microsatellite instability, and they maybe won't tolerate chemotherapy. So they have a higher performance status, a lot of comorbidities. There's some reason they can't get FOLFOX. Some providers will kind of skip right to the immune checkpoint inhibitor, but they are technically indicated in a second line or further therapy. And then regorafenib and the trifluridine and tipiracil, those are oral medications, but we're not going to really spend any time on those because those are really much later on therapies that we can use. There's some kind of interesting things pharmacy-wise about them, but we're going to focus kind of on the first-line options and then review a little bit of the immune checkpoint inhibitors again. All right, so these are kind of all the medications we haven't talked about yet on this lecture. We'll go through quickly Pembro, Nivo, and ipilimumab just because there's nothing really different in this setting. But just keeping in mind in a patient that comes in with diarrhea and they have colorectal cancer, kind of like the same thing we talked about if someone comes in with shortness of breath and they have lung cancer, there's a lot of things you have to consider before blaming it all on the immune checkpoint inhibitor just based on where their cancer is. But we'll spend most of our time with the other 5 that are listed on here because they're kind of new to you all, I believe. You've not probably talked about these medications quite yet. So we'll start with panitumumab and cetuximab. So both of these are the EGFR or epidermal growth factor receptor inhibitors. Unlike the ones for lung cancer, these are IV medications, and they get added on most of the time to the standard chemotherapy. So as you can see for toxicity, it's a lot of what we talked about with the oral EGFR inhibitors, so this acneiform rash. Interestingly, and this applies to some of the older oral EGFR TKIs as well, specifically erlotinib in lung cancer. But in patients with these IV treatments that develop the rash, or even the oral treatments, the older ones, that may correlate with efficacy. So it's kind of hard to tell patients that. I mean, you can, but sometimes they get a little worried if they don't develop a rash, and that means the drug's not working. So it's something worth keeping in mind. If they do, what I tend to do is tell them that it may indicate it's working, but it's not a guarantee, and just because you don't have the rash doesn't mean it's not working. But especially if they end up coming in complaining of the rash and want to stop the therapy, that might be a time to be like, this might mean that it's working, so let's keep on with it and try to add on some supportive care options for you to manage it. Both this and the cetuximab are monoclonal antibodies, so there's the potential a patient may react during the infusion. It's actually, especially with cetuximab, it's relatively common, so we go kind of slow, especially in the beginning. If you're looking, and I'm not sure if this would have been reviewed a lot with other pharmacotherapy lectures, but any thought as to why maybe panitumumab might not have as many infusion reactions as opposed to cetuximab?
It's human.
Yes, yeah. So it's a human. So panitumumab, based on the name, is the human monoclonal antibody versus cetuximab. It's not. So there's a potential for more reactions. The other thing you'll notice on here is the hypomagnesemia. So it's pretty common with both of these medications. Sometimes it's really low magnesium. Like no matter what we do, we cannot seem to get them to a normal range, which can cause a lot of other issues, cardiac, etc. Where you're trying to replete them with IV mag and it doesn't seem to be working. So I have seen patients either need to be on a lot of magnesium at home, which unfortunately can lead to diarrhea if it's oral mag, or even need dose or therapy interruptions with panitumumab and cetuximab because we can't maintain a normal magnesium. So that is an added part of the monitoring. It's pretty standard to get potassium and even a calcium with, say, your CMP or BMP, but a lot of centers don't automatically check magnesium. It's typically an extra lab, so just kind of keep that in mind. If you're not seeing magnesium results, it's because they haven't other targeted therapies, when we were assessing mutation status, we were actually looking for a positive mutation. It's actually the opposite with panitumumab and cetuximab. When we're looking for KRAS mutations, we're hoping that the patient is wild type. And the reason for that is if the patient has a mutated KRAS, this is a part of the EGFR signaling pathway that's downstream. And if a patient is mutated for RAS, the likelihood that the EGFR inhibitor will work is much, much lower. In fact, these are only approved in patients who do not have a KRAS mutation because when they first studied these medications, they didn't check for that mutation, but they found that some patients didn't respond and some responded really, really well. So they started to look for why might that be, and this is where they kind of found the break point. So in patients who have a wild-type RAS mutation, wild-type RAS status, they have significantly prolonged overall survival and response rates with the EGFR inhibitors. If there's a mutation present, then essentially the cell signaling is able to bypass the EGFR inhibition and continue to signal with the mutated RAS. So the EGFR inhibitor is not going to add anything to your therapy and just may lead to unnecessary toxicity, and these are also very expensive. So that is required to be tested for and confirmed as wild type before you do either of these medications. So cetuximab, as I mentioned, there's the potential for infusion reactions, but this does require pre-medication because the likelihood is a lot higher. So patients should receive an H1 antagonist such as Benadryl prior to their infusion. Otherwise, though, it's very similar toxicities and monitoring as panitumumab. The dosing is a little bit different. It's dosed based on milligrams per meter squared, and the first dose is higher, but that I won't ask you the dosing on the exam. Same with the RAS mutation status, confirming that the patient is wild type, and then monitoring your electrolytes. As you can see with the acneiform rash here, sometimes we'll put actually patients with cetuximab, that this tends to be where I see the highest incidence of the rash, so sometimes they'll just be put on prophylactic doxycycline or minocycline up front. In fact, I think the package insert recommends doing it for at least the first 6 weeks of therapy, just because that's when it can tend to be the most severe. And even though it may correlate with efficacy, if it's a very severe rash like we talked about with some of the oral drugs, this is patients really don't like it, especially since it tends to present on the face, but it can also lead to breaks in the skin and potential for infections. And in the first line setting, we're typically adding this on to systemic myelosuppressive chemotherapy, so we're trying to minimize how many potential sites of infection that we have. All right. So the next few monoclonal antibodies we're going to talk about are all going to be targeting this VEGF, or vascular endothelial growth factor receptor. The purpose of these medications in general, bevacizumab gets added on to several other types of chemotherapy regimens, specifically in gynecologic oncology. There's a big role for bevacizumab. I mentioned it a little bit with lung cancer as well. And primary CNS tumors, such as glioblastoma, can also use bevacizumab. The purpose of these medications is to essentially cut blood flow off to the tumor. So we know that cancer cells and tumors in general have a lot of angiogenesis and form their own blood supply and blood vessels. This interferes with that vascular endothelial growth factor, so hopefully cutting that off, and essentially, I'll try to explain it to patients at least, if we starve the tumors of blood flow. With that though, as you can imagine, if you're altering your vasculature at the tumor site, there's not really a way to not do that at normal vasculature. So the side effects are kind of related to the manipulation of VEGF in normal tissue. So hypertension is very common with these medications. Patients also can bleed. So in patients who, say, have a surgery or some sort of wound, if you're interfering with the ability of the body to perform normal angiogenesis, they're maybe not going to heal as well from those wounds, and that can also lead to bleeding. So there is, in the package insert, you have to hold any of these agents 28 days prior to and 28 days after surgery because of the impaired wound healing. So we didn't really talk much about this medication in the adjuvant setting. if there's a patient that needs some sort of surgery, either they need a colectomy for some reason, and making sure that the bevacizumab has been held the appropriate amount of time if they're going to get on it, and then maybe deferring it to a later cycle to allow for appropriate wound healing. This even comes down to patients requiring a port. So as I mentioned, if you're going to do FOLFOX and add on bevacizumab, they do have to have a port for the 5-FU infusion, so they won't be able to get bevacizumab with the first cycle. Since the port is an invasive procedure where they're actually putting the device into the chest wall, they can't get bevacizumab on the first couple of infusions, so it'll usually be held for that reason. Though it can cause bleeding, it can also cause clotting, and this would be both venous and arterial thrombotic events, so patients are at increased risk for VTE, and they can also be at increased risk for stroke and MIs. That tends to be on the more rare side of the thrombotic events, but when you factor in these patients are high risk in general because they have cancer, and depending on the type of cancer you're treating, there tends to be higher risk. So where these get used in other malignancies, we worry a little bit about clotting. And then if you have someone who's post-op, then of course they're also at increased risk. So it just tends to compound. So it's something to keep in mind. In patients who have an extensive history of VTE from maybe having a long-standing diagnosis of cancer, they may not be the best candidate for a VEGF inhibitor. Patients who have uncontrolled hypertension at baseline or on a lot of agents already, even if they are well controlled, they will often need adjustments on their antihypertensive. So these are kind of the patients where maybe these are not the best candidates to add this on, and that's why it's kind of a plus or minus on the recommendation. But focusing more, at least for the purposes of the exam, if a patient case is presented to you and they're on bevacizumab, kind of knowing these side effects and the monitoring parameters for them, and that they need, to be spaced out from procedures, that they can have hypertension, et cetera. So along with that, obviously we're monitoring blood pressure at the time of infusion, and if they're above a certain threshold, that threshold can sometimes vary a little bit if you're talking about a clinical trial versus what's done commonly in practice, but typically if they're above either 150 or 160 over 90, they're likely not eligible to get bevacizumab that day. But similar to what you learned about with general hypertension, it's kind of hard to take a one-time reading into account, especially if it's the patient is nervous, they don't like coming to treatment, et cetera. So sometimes we're a little flexible with that and push it up to 160, just to kind of accommodate for patients that maybe that's not their true blood pressure. And then patients are also at risk for developing proteinuria. So we do get urinalysis prior to treatment to check for protein in the urine. If it is above a certain threshold, then patients will often have to get a 24-hour urine where they essentially collect their urine as it sounds. Over 24 hours, bring it back to clinic and see exactly how much protein is being excreted into the urine, because this can indicate nephrotic syndrome and damage to the kidneys from the VEGF inhibitors. So it's a lot of different toxicities with these drugs as opposed to some of the other ones we've talked about. As you can see, for ramucirumab, this is also a VEGF inhibitor, so we're going to have kind of the same monitoring recommendations when it comes to urinalysis, blood pressure. There are potentially more infusion reactions with this medication as opposed to bevacizumab. For bevacizumab, we don't have to necessarily pre-medicate. We actually manage the risk of infusion reactions with the infusion time itself. So usually for bevacizumab, it will be given over 90 minutes the first time, and then if they tolerate it well, the risk of reaction goes down, so we're able to shorten it each time, where you're able to give it as short as 30 minutes, and I think there's even shorter infusion times off-label that other institutions do depending on the dose. So, but with ramucirumab, we usually at least give them the pre-medication with an H1 antagonist. Something a little bit more unique to ramucirumab is it can cause hypothyroidism, so the thyroid study should be monitored kind of similarly to how we would do the immune checkpoint inhibitors. If this is given every 2 weeks, you don't necessarily need to get a TSH and free T4 every 2 weeks. Sometimes that ends up happening, but as you may recall from your endocrine pharmacotherapy lectures, when you start someone on levothyroxine, you're not necessarily going to have the max response within 2 weeks. So you can kind of get it less frequently, but making sure to titrate their levothyroxine appropriately based on those labs. And then zivaflivercept is also a VEGF inhibitor. So nothing really necessarily special with this medication. It can cause cause diarrhea and myelosuppression, though bevacizumab has some monotherapy indications, so sometimes when these are used in combination, they're obviously going to have much more reported myelosuppression, but otherwise, though, very similar as far as toxicities. This is a class-based effect, so if you do an oncology rotation and get to interact with patients with kidney cancer, we use a lot of oral medications that target multiple receptors, but one of them is VEGF, so they'll have often these exact same monitoring parameters, exact same side effects, and it's all based on the class of being a VEGF inhibitor. So for when you're studying and thinking about these questions, if they were to come up on, say, board exam questions, VEGF inhibitors across the board will all cause potentially hypertension, delayed wound healing, hemorrhage, clots, and proteinuria, and it's all related to how they're interfering with vasculature. So it's a little bit easier to remember if you think of it that way as opposed to each drug individually. Alrighty, so just as quick review for nivolumab and pembrolizumab, we've talked about these a lot, but they are both the anti-PD-1 immune checkpoint inhibitors. I've listed for you the dosing. As you can see for nivolumab, it's the same as it was if it's by itself. For the other indication, it's either going to be 240 milligrams every 2 weeks, or more recently, 480 milligrams every 4 weeks. So that really helps with patient convenience if they're on just this medication, if they can come in once a month. It makes them very happy. When in combination with ipilimumab, it's that weight-based dosing. And then pembrolizumab is still 200 milligrams every 3 weeks for patients with colorectal cancer. So I have listed here for you again the same thought process for immune checkpoint inhibitor toxicity, treating with high-dose steroids and tapering over at least a month, sometimes longer to 6 to 8 weeks, and that we commonly will see the rash, colitis, thyroid dysfunction, especially hypothyroidism, but that patients can still develop some of these less common toxicities, and like we talked about with other lectures. We won't spend a lot of time on these. Unlike the other monoclonal antibodies that I've talked about that are typically in combination with chemotherapy for colorectal cancer, these are used as monotherapy. So it's not like lung cancer where we're quite yet adding these to frontline therapy. These are for those patients that are either MMR or MSI high on their genetic profile, so they have a lot of DNA instability. All right. So we'll go through the third case. So this is patient AB, a 65-year-old male who has stage 4 unresectable colorectal cancer, and they are going to be getting FOLFOX with cetuximab. Baseline CEA is 6.8, and the nurse has never administered cetuximab before and wants to know a little bit more about the medication. And this comes up quite a bit. We recently at the Georgia Cancer Center here in Augusta got all of these new nurses, so it was kind of fun. They had never really given a lot of these medications before, so they like to get a little bit of a crash course before they give it, what to look out for, what orders should be coming along with this medication in case it got left off by the physician, etc. So just take a couple of minutes to answer what mutation we should be looking for and what the results should be before the patient gets cetuximab, and then what are some little pointers you want to give to the nurse before she starts the infusion. All right. So what mutation and results are you hoping to see in the chart before the patient gets cetuximab?
Wild type.
So wild type RAS, very good. And then any pearls you want to provide to the nurse about what to expect once she is about to start the infusion.
Infusion reactions.
Yes, so infusion reactions. So the way we typically manage an infusion reaction if it happens is, you'll stop the infusion and then give emergency medications, but letting them know to expect certain pre-medications that the patient must at least receive the pre-medication with an H1 antagonist, and that if there is an infusion reaction, to pause the infusion, administer additional emergency meds such as another dose of an H1 antagonist if they weren't maxed out on the Benadryl, but typically they'll also get a steroid such as Solumedrol, something relatively quick acting, and sometimes an H2 antagonist as well. The very severe reaction, and we have to do something along the lines of epinephrine, nebulized albuterol if they're having an airway issue, that can happen, but usually patients, it's relatively mild, but can be somewhat alarming. So once it's resolved, then they can resume at a lower rate, and usually patients will do okay with that. Subsequent doses, the risk of reaction will go down, but they should receive the H1 antagonist at least as a pre-medication. And then some patients, if they have a history of reaction, will kind of get escalated on their pre-meds and get the steroid up front. The nice thing, or something to keep in mind, if it's a patient like this where it's FOLFOX plus cetuximab, FOLFOX tends to be a moderately emetogenic chemotherapy, so they'll typically get dexamethasone as well as a pre-med for that, so that kind of helps to prevent infusion reactions from the cetuximab, but they should still get the H1 antagonist on top of that. All right, so, and just to remind you of his baseline CEA, so it was 6.8. 3 months later, they're checking the CEA to assess response to therapy, and it comes back and increased to 12.4. So this kind of prompts a CT scan to see what's going on, and the CT scan confirms that the patient has had disease progression. So the patient was on FOLFOX before, so commonly they'll then get switched to something like FOLFIRI, and the physician has decided to try adding on bevacizumab as an option. And after 2 cycles, the patient comes to clinic, says he's doing really well, but that he has an elective surgery scheduled next month. So what would you like to tell the patient and the oncologist as far as modifications to his treatment?
Hold the bevacizumab.
Yes, so someone here in Augusta said hold the bevacizumab. So for sure, excuse me, make sure to hold it. It should be at least 28 days prior to an elective surgery, and then it should be held for the 28 days after. What sometimes will come up, unfortunately, is if it's not an elective surgery and it's more emergent, and so more, if you have a patient that, say, gets admitted for a completely, potentially unrelated reason, but you find out when you're looking through the record that they're getting something like a bevacizumab-containing regimen for treatment of their cancer, but the surgery is required to happen, that the team is well educated, especially if it's a non-oncology team, on the potential interference with wound healing, but sometimes you don't have a choice but to proceed forward with a surgery. So this would be, say someone comes in as a trauma or something like that, and they have to have an emergent surgery performed. So something that maybe your non-oncology physician colleagues wouldn't be as aware of, but something to keep in mind as a patient's post-op care proceeds when they're in the hospital. All right, so let's say it's 8 weeks later, after they've resumed their bevacizumab post-surgery, and he has a really bad headache. It's actually been going on for the last 4 to 5 weeks, and he's been using all these over-the-counter pain relievers, and it's not working, and then he's also coughing up blood and has black tarry stools for the last 3 days. So it's like the worst-case scenario, but you never know. Patients are, I will say, it's just a side note, patients sometimes are hesitant to report things that are going on because they know that maybe it will interfere with their ability to get treated for their cancer. A lot of times they're very upfront about it, but sometimes patients they just hesitate because they don't want their cancer treatment to be taken away. So it's something to keep in mind. You have to do a little bit of probing sometimes. But these are the labs and vitals when he comes into clinic. As you can see, the white count's 3.8. Hemoglobin's a little low, 8.2, and if they're having black tarry stools, that might be why. Platelets are 103,000, and depending on when they last received FOLFOX, that could be related to or FOLFIRI, that could be related to the chemotherapy. And then his blood pressure is 184/112. So anything that you want to do differently about this patient's treatment at this point, with all these things they're talking about. In Athens, anything you want to do differently, or at least what you think might be going on?
Maybe the bevacizumab is causing hemorrhage, and that's kind of why we're seeing the blood being coughed up, and then also causing some hypertension. So don't know if that's something that we could dose reduce, or if we would want to hold it all together.
Yeah, so that's a really good question. There's the potential to dose reduce, but a lot of times, for the most part, if he say came in and this was a treatment day and the blood pressure was like this, we would just hold the bevacizumab altogether. The hypertension may happen kind of regardless of dose. In someone that's also having active bleeding, if they're having a really bad headache and they also have high blood pressure and their platelets are a little bit low, and we don't know, like, were they lower a week ago when the headache was way worse, what over-the-counter pain relievers are you taking? Is it all this ibuprofen? If you're worried at all for something like a hemorrhage, like a brain bleed, and that's possible. These platelets are not quite low enough to spontaneously bleed, but if they were lower last week and he was doing all this other stuff with ibuprofen, say, then that would be a concern. But in this case, it might be that if the patient is having all of these issues with their hypertension and bleeding, that they may no longer be a candidate for the bevacizumab and to kind of get rid of it altogether. Oftentimes, the bevacizumab, it may help a little bit, but keeping in mind that if they're on chemotherapy with the bevacizumab, the chemotherapy is doing kind of the bulk of the work when it comes to treating the cancer. So at this point, it almost seems like the bevacizumab risk outweigh whatever benefit you might have received with it. So it's reasonable to just discontinue it altogether. And that's probably what I would say in a case like this. It would be really, you'd be hard pressed to re-challenge if you think all of the bleeding and everything is related to bevacizumab, because it could just get worse over time. And then another thing to just kind of keep in mind with platelets of 103,000, so a lot of times when patients come to clinic, the physician and the treatment plan will dictate at what point the ANC needs to be above and at what point the platelets need to be above for them to proceed safely with chemotherapy for that day. And oftentimes platelets of 100,000 are kind of our cutoff for a lot of regimens. There's some where it's a little bit lower, but for a lot of regimens, we want those platelets when they come in for treatment to be above 100,000 so that we know it's safe. In someone who's borderline like this and also bleeding, that's when you would, even though the number lines up, you take into account your patient's specific scenario, and it might mean that if their platelets are dropping too low in between treatments, that you might also need to modify the actual doses of the chemotherapy, because that's probably what's causing the low platelets as opposed to the bevacizumab. But all things to kind of think about when they come in with these acute issues while on treatment. All right, so case 4, I think this is the last case, and this one hopefully will be a little quick, but this is patient DM, so it's a 48-year-old male. He has stage 4 unresectable colorectal cancer, and actually on the his mutation analysis, he's found to be MSI high, and then the oncologist wants to know what options are available for the patient based on his genetic findings, and then the patient lives about 3 hours away, would like the most convenient regimen possible where they don't have to come too often. This actually comes up quite a bit with patients where if they're being referred to an academic medical center, they have to travel quite a bit in order to get treatment, because some of these medications may not be available at their local cancer center. So in his past medical history, he has type 2 diabetes, high cholesterol, AFib, also has a history of migraines and hypothyroidism. I've noted his mother died of colorectal cancer at age 58, and there are the medications that the patient is on. He's supposed to be on metformin, but discontinued it because of GI upset about 3 months ago. So based on the fact that the patient is MSI high, lives kind of far away, are there any regimens that are kind of jumping out to you that you think might be a good option for this patient? See here in Augusta if anything comes to mind.
Pembrolizumab?
So somebody mentioned pembrolizumab, definitely an option with MSI high. Any others that you want to think about?
High-dose nivolumab.
Yes, and then there's the nivolumab at maybe the higher dose. The 480 milligrams, you could do it every 4 weeks if that's agreeable to the patient and they'd rather come every 4 weeks instead of every 3 weeks. But neither of them are wrong, and the patient can kind of decide which to use. We don't have really, in any of these malignancies where we have multiple immune checkpoint inhibitors approved, we don't really have any head-to-head prospective trials to say one is better than the other. I doubt that will ever happen. But they're all relatively the same efficacy, and the safety profile is the same. So sometimes it really does come down to convenience, and the patient would rather come every 4 weeks instead of every 3 weeks. So you end up picking nivolumab. It has kind of prompted the makers of Keytruda to figure out if they can get away with 400 milligrams every 6 weeks. Haven't heard an update yet, but they'll keep trying to spread them out. baseline monitoring, let's say we decide to go with nivolumab every 4 weeks. Any baseline labs and what you'd like to tell your patient about starting this treatment? How about based on his past medical history? Anything in particular that you may want to mention to the patient?
We're using the monitor's thyroid function. Do you have a history of hypothyroidism?
Yes, very good. So making sure to monitor the thyroid studies, that happens across the board, but it's worth telling a patient that's already on something like levothyroxine that there's a chance we're going to have to adjust your dose. And it's probably something they're used to, but letting them know that the medication may cause a dose adjustment in the future. And then, of course, monitoring renal function and liver function tests for those more rare but serious side effects like nephritis or hepatitis, and letting the patient know to keep an eye out for any diarrhea that develops once they start treatment, and going over kind of what to do. I do like to kind of give patients an overall timeline of here are some things that may happen earlier, that you may develop a rash a little bit earlier, but then a few months in you might start having diarrhea, and let them know that it's not uncommon for there to be a delay to the side effects.
Still there.
Yeah.
Oh, okay, well, we don't need to do that. And then, so yes, talking about especially the thyroid function. So this comes up a lot, and I did want to just make a point of this. If you have somebody with pre-existing hypothyroidism, I doubt anybody would say, is it okay to give nivolumab even though they have it, because it's so easy to manage around. But sometimes you'll have someone who has, say, a history of rheumatoid arthritis, and that's an autoimmune arthritis, and maybe they're already on an immunosuppressive regimen of some kind, and whether or not they can get an immune checkpoint inhibitor. There's a lot of gray in those questions. In a lot of the clinical trials, especially the earlier trials, anyone with any history of an autoimmune disease was excluded. More recent trials, it's more if they are stable and don't require systemic immunosuppressive therapy, it's okay for them to be enrolled. And they've even relaxed it further that as long as it's certain immunosuppressive therapies, like Plaquenil maybe would be fine, but if someone requires low-dose prednisone all the time, that may not be okay. So it comes up every once in a while. Sometimes people, they start thinking about it, realize that, oh, is it okay to start those patients on these types of medications? And a lot of it really depends on how much treatment they're requiring for their autoimmune disease, if it's well controlled, and then what other options do they have for their cancer. And so then it becomes a conversation to have with the patient. We had this come up with a lung cancer patient who had rheumatoid arthritis that really would be nice to have put him on pembrolizumab, which we ended up doing, but it was someone that actually required a lot of treatment for his rheumatoid arthritis, but he was insisting on having the pembrolizumab. A lot of these medications have a lot of commercials. Keytruda has a lot of commercials for lung cancer, so patients kind of come in asking for it and say that they will just deal with it if they have, say, an RA flare, but it's different than once they actually have an RA flare and are in a lot of pain and need high-dose steroids, then kind of what we do after that. But something to just kind of keep in mind. It's not a reason, in this case for sure, to not give someone an immune checkpoint inhibitor. And so then after his 4th infusion, so we're about 12 or 13 weeks out from starting, this patient comes to the ER, has severe dyspnea, non-productive cough. They see those ground glass opacities on a CT scan of the chest. And so they have ruled out all other causes of this presentation and have decided the patient has grade 4 immune-mediated pneumonitis from his nivolumab. So how would you treat this pneumonitis, and what are some supportive care issues that you want to address with this patient and with the team? So let's take a couple minutes to do that. All right. So how would you, just kind of broadly speaking, how would you like to manage this patient's pneumonitis? pneumonitis, so probably more on the 2 milligram per kilo end rather than 1, but definitely that 1 to 2 milligrams per kilo to start out with. In someone who's come to the ER and has been admitted and it's this bad, it's probably going to be IV methylprednisolone at first, but just broadly speaking, high-dose steroids, we're going to taper over at least 4 to 6 weeks. And if it's this severe, probably on more the 6-week end. What supportive care things do you want to make sure get addressed by the team, and then what do you want to counsel the patient on? So yes, this person has that history of type 2 diabetes, and he took himself off his metformin, so he's probably not very well controlled at this time anyway with his diabetes. This is not going to help. Definitely making sure to tell the patient, if it's appropriate, they need to restart their metformin or hopefully have at some point, and that they may need to monitor their blood sugar at home. Same with things like hypertension, may all be worse, and then those infection prophylaxis recommendations that we talked about with the last lecture. So he's going to be on steroids for at least 4 weeks, so considering maybe the PJP prophylaxis with something like Bactrim, and if the taper is going to be extended to more like 6 to 8 weeks, if whether or not the patient's going to need antifungal prophylaxis with something like fluconazole. Another important thing to note with the past medical history, so this is a patient that has a history of AFib and is on apixaban. So this is somebody where you may want to consider upfront stress ulcer prophylaxis since he's on a systemic anticoagulant and would be at a higher risk for a GI bleed. This is someone that it may be very appropriate to go ahead and start on either an H2 antagonist or a PPI. So kind of keep those things in mind. Otherwise, all the similar patient counseling you would do at discharge with the taper, making sure they take the steroids with food, preferably in the morning, though often at these big doses we have to split them up into 2 doses anyway, at least in the beginning, but kind of helping patients to figure out a good time to take it with a morning and evening meal, and assessing whether or not they're having issues tolerating the steroids. I found like longer term, these patients, they will start to come to clinic complaining of some other side effects like insomnia and agitation. We had one patient that was having the person had brain mets, but then they also developed some immune-mediated side effects from their immune checkpoint inhibitor therapy. So they were on dexamethasone for the brain mets in the first place, and then we had to prolong the taper, and the patient thought he was doing just fine, and his wife had a very different interpretation of how he was behaving at home. So it becomes an issue, especially longer term. So they tend to follow up in clinic very frequently, at least weekly, to check labs, but then also hopefully taper them off the steroids as safely and quickly as possible. So those are some other things to think about, the normal side effects from steroids these patients will start to experience. So then, of course, he's been on his high-dose steroids, and actually his shortness of breath is much, much better, and he's feeling really, really good about the treatment of the pneumonitis. So the oncologist wants to know when he can resume his nivolumab. What are your thoughts on resuming the nivolumab? Somebody here in Augusta said don't. So typically with a grade 4 pneumonitis, this would be an indication of permanently discontinuing immune checkpoint inhibitor. If it were grade 2, we could probably re-challenge later, but since this person was only on nivolumab and it was grade 4 requiring hospitalization, etc., this is someone who's not really a good candidate to resume. The question then becomes, well, can we just switch them to pembrolizumab or something like that? There's not good information that that's going to reduce your risk at all, because it's more of a mechanism of action side effect as opposed to drug specific, so that's probably not going to be the answer. And even patients who have had, say, disease progression on one, switching to another, they tend to have worse outcomes. So once you kind of burn the bridge with an immune checkpoint inhibitor, it's for all of them. So just something to keep in mind. It's kind of the class itself gets ruled out once they either progress on it significantly or have a really bad toxicity from it. Alrighty, any questions about these?
Would you also get chemo?
So the question here was whether he would get chemo along with the nivolumab. Usually, no, not for colorectal cancer. They'll usually get this as a monotherapy. Didn't talk about it much in the case, so in a very fit patient without a lot of comorbidities, they would typically get chemotherapy first, and then this would be something after they've progressed per the package insert study design on at least an irinotecan and oxaliplatin containing regimen. In practice, a lot of providers won't go through both lines, and they're kind of retroactively looking at that, and that might be okay. But in someone maybe with who's really poor performance status and won't tolerate FOLFOX, you could consider doing this upfront, though that would be considered off-label and not preferred if they can get any other chemo first line. But as far as I know, I mean, I'm sure there are studies, because they're doing it with a lot of other cancers, there may be studies going on right now to see if we add this to the traditional frontline chemo, if that's better than doing it sequentially, and that's what happened with lung cancer. We did it first in the second line and then bumped it up in combination with the chemo, and patients did better, so I'm sure it's being looked at.
So what would be that patient's options then? Did you say if they can't get the immune checkpoint inhibitors anymore?
Oh, that's a good question. So the question was, in this particular patient case, if they can no longer get an immune checkpoint inhibitor, what would be their other options? So it would depend if they had previous, we'll say for the sake of the example that he had received FOLFOX and FOLFIRI first. So this patient's being treated exactly as the package insert recommends in the FDA approval, and then now they're starting nivolumab. That's when we start to consider some of those second line options that I have listed, such as regorafenib or this trifluridine with tipiracil options that are oral. There's other chemotherapy options that maybe the patient hadn't received. There's kind of quite a long list actually of things in the subsequent line that we didn't get a chance to talk about. But if someone had both FOLFOX and FOLFIRI and got an immune checkpoint inhibitor, if he was KRAS wild type, you could do something like panitumumab or cetuximab. Sometimes patients get those as a single agent if it's much later on. Or there's these oral drugs that are an option. The trifluridine with tipiracil is a very interesting dosing schedule for patients. They have a calendar, and the two drugs are dosed differently. And very interesting medication. So in the third and fourth line, patients did okay, but at that point, if you've had that many lines of therapy and they're still not working, then that's when you're less likely to have a response. The good thing, or a potential bright spot with immune checkpoint inhibitors, is if they do have a toxicity like that, but they were responding, they'll tend to maintain their response even if they have to be taken off the medication. Once the immune system kind of knows what to do, they'll still get that benefit even if they're not actively receiving the medication. So some people will continue to respond even after the drug is taken away for several months or even longer, depending on how well they responded in the first place. And then real quick, before it ends, I am going to be sending Dr. Clemens, because I know you guys didn't have the slides for melanoma and lung before the lecture, so I'm going to send her 1 or 2 page summaries, study guides for those, and I can do one for colorectal too, but I think hopefully you all have the slides beforehand, go for what to focus on for the test. So hopefully those will be up by Monday or so, maybe sooner.
Thanks.